All right. Good morning. Top of the morning from Albuquerque, New Mexico. I hope you guys are having a great beginning of your new year. And we wanted to just start today by expressing some gratitude. I think it's important that we start that new year from that spirit of thankfulness, especially to the AUA and the Journal of Urology, as well as to the AUA guidelines committees and panels. And you can see them here from all across the Americas, bringing to us the guidelines and the safeguards that allow us to care for our patients and be their guides to help them be the best version of themselves. And it's a process, obviously, just like this Rodin sculpture, the thinker, it keeps evolving forward as we continue to perfect it and improve upon it. And we're grateful because when we put out the LinkedIn poll, 74% of you felt that the AUA guidelines was the most influential for the global management of BPH and BPO patients. These guidelines are really important. That's why we were so excited to see that the AUA amendment to the guidelines came out just this January in the Journal of Urology. So 74% of you feel it's the most influential guideline. So we look to it for more guidance to help our patients together. Quick other gesture and comment of gratitude to all of you out there who make up the Man vs. Prostate tribe. The urology residents excite me to see that they are joining the tribe because they are the future. They are the future of the BPH BPO guidelines. They are the future of how we care for our patients and how we together save more bladders. So thank you to all of you who are joining the tribe all across the world, from Beirut to Pakistan to Canada, as we can see here on this slide. Some housekeeping details. I'm going to try and have us all meet on Thursdays at 6:45 Mountain Time, which is 1:45 p.m. Greenwich Time. Thank you all for being CEOs in your lives. That is Chief Energy Officers. Thank you for looking at how you inhabit your space and how you can transform it in a positive way. Together, we do believe in the 4 agreements by Miguel Ruiz, which is, hey, we're all just trying our best. We're being impeccable with our word. We're not making assumptions and we're not taking things personally. Together, we help each other. We help our patients face and embrace and move through fear. Remember, fear is just a 4-letter acronym for face everything and rise. And together we are creating a BPH BPO pathway for a man who pees, which is an acronym for personalized, effective, efficient, simple, and safe. That is the type of pathway that we are creating together. Other housekeeping note, I have decided for this year I'm going to take off the cowboy hat, and it has a spot there on the back wall. It was just affecting how I was presenting, having this big thing on my head. But it reminds me of the dangers and the harm that can impact the lives adversely for our BPH BPO patients. One of my very first patients in 2006 was living a miserable life, and he had been a victim of the polypharmacy epidemic. No one bothered to do a diagnostic evaluation. They just kept giving him more medications or higher doses. When I finally met with him and discovered he had a 200-gram prostate, I offered him an open, simple prostatectomy at that time, was what within my tool set, or he could keep living that life of an IPSS in the 30s, completely lacking in vitality and a miserable man. He chose the path that he could control, his preferred path. So he took a gun and he shot himself and killed himself over his BPH, BPO, lower urinary tract symptoms. So remember, what we do improves lives and saves lives. And that's really important for us to remember. And together at the Man vs. Prostate Tribe, we believe in the triple Ps, the PPP, the power of P. We are prioritizing the preservation of bladder health. We are trying to put an end to the polypharmacy epidemic, and we will talk about that a little bit more. And we are trying to prevent late-stage BPH BPO, stage 3, urgent incontinence, stage 4, acute urinary retention, stage 5, bladder failure. Together, we do believe that words matter. It's called linguistic determination. The habitual uses of language influence our habit of thought and action. Words matter, it affects our thoughts, our actions, and our habits. And together, we need to focus on that because it can really affect in a positive way how we guide our patients together. As words matter, our one word, as you know, for myself, I chose the word abundance for 2024. The pandemic in my life, personally and professionally, really allowed a scarcity mindset to really weasel its way into my psyche. And so I chose abundance. And for us as a tribe, our one word that brings us and speaks to our mission and our passion is prevent, from the Latin prevent, to act in anticipation of. We can anticipate that late stage BPH BPO is coming to our doorsteps. It has already arrived in Sweden. It has already arrived in the UK. And we need to act in anticipation of this growing tsunami of late stage BPH. As a quick side note, I believe that some of you may be able to place some comments. Feel free. I'm going to try and be able to field those as I go along. I may not, since I am trying to work both screens, but feel free to try and do that. I'd love to try and answer any questions. And we are acting in anticipation that bladder health and late stage BPH is on the horizon for many of our patients. This is a great slide contributed to by the research of Defender Amanda Chung from Australia, who's done just great contemporary work on looking at electron microscopy, showing that we go over time and we progress as we see bladder outlet obstruction, detrusor underactivity. We begin to see the homogeneous detrusor fibers begin to be destroyed catastrophically, microscopically, but also macroscopically, as we all can use our cystoscopic swords. Trust the truth of trabeculations. That is a sign of a bladder that is dying, dysfunctional, struggling, that needs your help, needs our help together. As a result, that's why I came up with the 5 stages of bladder health. Words matter. We needed a way to talk about what's happening. And to be able to say late stage BPH, it is something that draws us together as a common enemy, as defenders of the detrusor. We are trying to prevent these late stages: stage 3, urge urinary incontinence; stage 4, acute urinary retention; stage 5, detrusor underactivity. Together, we can prevent these late stages. Big shout out to the Italian brigade of defenders led by Luca Cindolo. Please look up a great editorial on prostate cancer and prostate diseases that came out in October of last year, where they really did a nice job of highlighting from an academic perspective these 5 stages of bladder health that I created for all of us to use. As a result, this is a garage-grown, grassroots effort, and it starts in simple places, just like the kitchen here in my office. And today I'm asking all of you to look at my post from today, where I highlight what we've been working on, what I've been working on over the last 2 years on this dry erase board. Obviously, on the top, the 3 priorities: preserving bladder health, preventing late-stage BPH, putting an end to the polypharmacy epidemic. And I'd like to get your input on this kind of outline of a different way to look at the pre-treatment phase of BPH BPO care, where we're trying to get more men in for a bladder health counseling and a bladder health baseline, so that we can risk stratify bladders, so that we can deobstruct the right prostate for the right patient at the right time within the window of curability when it is warranted. The other thing that we have really thought about carefully is that we need to relegate medications to its proper category of a temporizing measure, not a therapeutic measure. So I look forward to your feedback. Nothing set in stone. Please feel free to be fierce with your feedback. That's how we're going to evolve forward together and make positive change. So when we look at these guidelines of 2023 amendment, let's just start with the title. Words matter to us. I think that BPH, we can all agree, is a histologic diagnosis. I personally don't treat histology, but I understand that the word and the term BPH has now, I think, forever been cemented into the vernacular of patients as well as physicians, especially here in the Americas, and I suspect in many places worldwide. We all know that BPH is histologic. BPE, or benign prostatic enlargement, is the prostate just simply getting bigger. And then when we have evidence of outlet obstruction urodynamically that we can attribute to that enlargement of the prostate, we can call that benign prostatic obstruction. I think that we as a tribe are willing to compromise. I don't think we have to be adamant about saying, hey, technically it's BPO, not BPH. I think moving forward, I think BPH / BPO used in combination is a fair compromise. I think as we continue to sculpt the AUA guidelines, just like that Rodin sculpture, the thinker, I think we can now begin to elevate our prime directive. And we've talked about this in past presentations and talks, where currently it says management of lower urinary tract symptoms attributed to BPH. I would say let's up our game. We can do better. Let's try. Let's see what happens when we try and use different words where we say, hey, what happens if the title says the preservation of bladder health with BPH BPO? When we use those words, the preservation of bladder health, how does it change? How does it nudge? How does it help us evolve the guidelines in a positive direction forward? Let's see. When we look at the amendments from 2023, words matter. How many times do we actually talk about the bladder? Remember, the bladder is simply amazing. Remember, there's only two major organs that cannot be transplanted, the brain and the bladder. We need to take care of it. It is that precious, and we can do that together. As we look through the AUA Guidelines 2021, Part 1, Part 2, the amendment from 2023, how many times are we saying prostate or detrusor? How many times are we saying prostate? And then how many times are they said in relation to each other? In 2021, Part 1, it was said prostate was said with a predominant ratio of 3.6 to every one time we said bladder. Part 2, prostate was mentioned 3.2 times every time bladder was mentioned. And for the amendment, that ratio was 5.4 to 1 for the ratio of prostate to bladder and detrusor, for an overall average of approximately, overall, for all three parts, a ratio of 3.7 to 1. At a minimum, shouldn't it be at least 1 to 1? Please, can the prostate allow the bladder to share the spotlight? We need to let the bladder come onto the red carpet. It is that important. We need to pay at least equal attention to the bladder. When we look at the introduction, what was interesting to me of note, first of all, in the amendment, bladder was only mentioned 4 times. It was mentioned twice here in the introduction, of which one is really about the bladder neck, not the bladder. But within the introduction, there's a sense of a cognitive dissonance, like we're trying to reconcile something, and I think we can help there. Despite the this is what it says, despite the more prevalent and often first-line use of medical therapy for men suffering from LUTS BPH, there remain clinical scenarios where surgery is indicated as the initial intervention for LUTS BPH and should be recommended, providing other medical comorbidities do not preclude this approach. There's a kind of indecision, uncertainty there. And I think we can reconcile that cognitive dissonance, and it's with accurate data. Let's get bladder health baselines. Let's understand what is going on with that detrusor function. Why do I say that? Accurate data drives appropriate decision making. That's what we're here to do. We are our patients' guides. We are the Gandalf to their Frodo. We are the Yoda to their Luke. And part of that cognitive dissonance is that we are putting a lot of emphasis on medications, which have their role. But at the end of the day, BPO is a mechanical problem, benign prostatic obstruction, a mechanical problem that deserves a mechanical solution. It's very simple, similar, as we urologists know, to a kidney obstruction or a ureteral pelvic junction obstruction. We don't just stop if we give pain meds for a guy with flank pain because of a kidney blockage and call it a day because the symptoms improved. In fact, our journey just begins for that kidney blockage. We want to identify where that blockage is. We get a CT scan. We also assess for renal function because we want to save every nephron that we can for that kidney. And we do all of that for an organ that is not only transplantable, but actually has a spare on the other side. For the non-urologist, I think Defender Ricardo Gonzalez has a great analogy where he talks about, hey, would you give just Tylenol for a brain tumor? No. Tylenol may improve the symptoms, but there's a major problem that needs a solution. That brain tumor needs to be treated, needs to be taken care of, needs to be removed potentially. And I want to be very clear about who we are. We are not against medications. We are pro-diagnostics, we are pro-data, and we are pro-bladder. There's a time and place for everything. And to make those decisions, we need accurate data that can drive appropriate decision making. Something that I forgot to do, which I normally do, is at the beginning of every huddle, just reminding us what our vision and our mission is. Our vision, remember, is to help our patients live lives well lived, chemical free and catheter free. And our mission is simple. We are here to empower our BPH BPO patients with the educational experience to make the best decision about their prostate even faster by highlighting what's at stake if the choice is made not to do anything about their prostate. So moving on from the introduction, it just highlights that our current pathway has three parts. There's the pre-treatment phase, the treatment phase, and the post-treatment phase. And we have done wonderful work. We are living now in this golden era of so much technology. And right now, currently, the pathway that we have put together has drugs as well as 4 surgical categories within the treatment phase of our pathway. But I believe we can do even better. We can evolve forward together. We can continue sculpting that sculpture to refine it. When we look at the guideline updates, the amendment, there were 9 updates. All 9 were about the treatment phase, looking at medications and deobstructive technologies. None of them were focusing on the pre-treatment phase. To be very specific, of the 9 updates, 44% or 4 of the 9 were about medications, combination of medications, highlighting even more combination of medications that we can now introduce into a man's body that will go on to touch every cell in their body. I would submit, are medications actually the most invasive because they touch every single cell in the body? Something to think about. And then the remaining 56% were about deobstructive technologies, which we love. I think it's great. But I do think that we need to shift the focus to prevention. That is our one word, to act in anticipation. Several things need to happen. I think we need to move medications to a separate category of the temporizing measures, like a Foley catheter. And that buys us time to spend and be more efficient in the pre-treatment phase where we can do bladder health counseling, bladder health baselines, and talk about screening men for bladder health. Figure 1 it has a lot there. It would take us an hour to go over it. But I do think it's time for us to think of doing an overhaul, an improvement potentially, where what happens when we look at improving the effectiveness by prioritizing the bladder, by prioritizing the preservation of bladder health? What happens when we try and make it more efficient by having an approach that's data first and pro diagnostic? Remember, we talked about accurate data drives appropriate decision making. And why? Why would we want to do an overhaul? It's because the modern man is changing. Modern men want to be guided with their data. Everyone's got a smartphone, everyone's got a smartwatch, heart rate variability, continuous glucose monitoring. Guys like their data. Everyone likes their data. I think we need to explore whether or not there are specific triggers that would prompt a bladder health baseline. Should it be some combination of like an IPSS over 7 plus, either a PVR over 100 cc's or a Qmax less than 15 cc's per second? Let's explore what happens when we screen men for bladder health issues starting at the age of 60. And let's make it required that these BPH, BPO, LUTS patients who we see get the proper counseling to understand what are the consequences if the choice is made not to do something about the prostate. Let's talk about getting a bladder health baseline for all these men when the criteria are met. And let's risk stratify these bladders based on how at risk are they for death and dysfunction, and then allow us to proceed with timely deobstruction with the right tool. Jeff, thank you. You are the very first. I'll be honest. I don't even know if people are on this thing sometimes. Thank you so much for even uh, putting a comment on. I really appreciate it. Together, we can make a change. So once again, meds are temporizing. They have their role. But when we call it a therapy, it gives it false credibility as a solution for a mechanical problem. In fact, we devoted a whole figure here to just medications. How about a whole figure dedicated to bladder health counseling? A whole figure dedicated to a bladder health baseline? How about a whole figure dedicated to risk stratifying bladders? Which bladders are at risk for death and dysfunction, that are at risk for entering late stage BPH, stage 3 urgent incontinence, stage 4 acute retention, stage 5 bladder failure? So we can intervene for the right prostate, for the right patient at the right time within the window of curability when warranted. And finally, here, figure 3 talks about using prostate size as the solo main criteria for how we choose deobstructing technologies. We need to expand upon that. Yes, size is important, but shape is equally important. Detruser function is equally important. How at risk that bladder is for death and dysfunction for late stage BPH should also be a determinant. So I look forward to us evolving forward into a more sculpted guideline on how we choose deobstructing technologies based on the big trifecta: size, shape, and detruser function. And I get it. I see where these guidelines came from. They came from the 1980s. So what we have done at Man vs. Prostate is we kind of created this patient decision-making aid. I'll be honest, we have so many technologies, I was losing it. And it became hard for me to communicate to my guests, my BPH, BPO patients, all the different categories and all the advantages and disadvantages. And so what we did together, I created these 4 categories: the least invasive surgical therapies, most invasive, minimally invasive, invasive, and most invasive. So list, mist, ist, and most. And I broke it down to very big, broad terms. Is it using a permanent technology? Is it not using a permanent technology? So the least invasive is non-permanent, and all the other 3 technologies are permanent. The place of service. So for the least invasive surgical therapies, for the most part, as well as for the minimally invasive surgical therapies, for the most part, are done and can be done in the office. for the invasive surgical therapies and the most invasive often done in the operating room theater in the hospital. And then to have some analogous um, correlate to the American Medical Association sense of risk, they categorize it into 4 categories: minimal, low, medium, high. So I just wanted to parallel that. And back in the 1980s, we had very minimal options. We had no options for the least invasive surgical therapies, the minimal invasive surgical therapies. All we had was electrosurgical, TWIPs, TUIPs, TURPs, and for the most invasive, we had open, simple prostatectomies. And at that time, we wanted something that had a more favorable risk-benefit profile, and that was medications. Because at the time, the morbidity and mortality of these procedures, TURP and open, simple prostatectomies, was high. But now we are in the surgery of this golden Renaissance era, and things have expanded exponentially. The AUA Amendment 2023 did a nice job of just kind of benching TUNA and TOMT, microwave therapy. But I do think it had a nice job of just highlighting we now have ITIND for the category of LIST, the least invasive. It had some nice mentions of prostatic arterial embolization, in addition to so many other minimally invasive surgical therapies. It did highlight lasers and enucleation for the invasive surgical therapies. And I think we need to now move on and say, look, medications are not therapeutic, but they are temporizing. They buy us time to allow more time for the pre-treatment phase so we can do a better job in the decision-making process of when do we deobstruct. Man versus prostate's perspective is, hey, do what you do well and do a lot of them. I think I heard something similar that defender Stephen Kaplan had said, and I think in his sage advice, I think, yeah, do what you do well and do a lot of them. Save as many bladders as you can. We all will win if we have that approach. Device companies, diagnostic companies, patients, practices, physicians, as well as our healthcare systems, which are under duress and are beginning to buckle under the strain of modern medicine. And most importantly, when you look at those 4 categories of list, missed, ist, and most, have an offering, an action plan in place for each of those categories so that you can personalize a plan for your BPH BPO patient. Meet them eye to eye, shoulder to shoulder to help guide them to the best decision for them, their body, their vitality. And then the amendment ends with 2 paragraphs, one about future directions. I get it. We're all in this world of EDL, inclusion, EDI, being equitable, being diverse, and being inclusive in what we do. I think that is fantastic. In addition to that, I guess I would hope that can we now begin to optimize the efficiency of decision-making process for deobstruction based on how at risk a bladder is for death and dysfunction? Can that be a future direction? We would love to see it. I get it. Hey, look, this is a grassroots effort. We're not academics, but something to think about. And then when we now look at the allocation of resources under the last paragraph of new therapeutic options, I guess I would throw out a word of caution. Are we at a place where we want to devote more healthcare dollars, research efforts to expanding the ceiling of medical therapy? I personally, I don't really think we need more chemical combinations to put in the bodies of men to touch every cell in their body. I think there may be merit in reallocating resources to improving public awareness of late-stage BPH BPO. I mean, think about it. Every person out there has the public awareness that if you have chest pain, shortness of breath, hey, I could be having a heart attack. I better go to the emergency room. I ought to seek help. Well, we need to increase the public awareness, urgent incontinence, urgency, frequency. Those all could be signs of a bladder that is struggling, dying, becoming dysfunctional, and you need to seek help because you only have one bladder, that amazingly complex bladder that's not even transplantable. And how about potentially allocating more resources to more research on that pre-treatment phase? Should we look at a PVR more than 100 cc's as a trigger to a bladder health baseline? How about just screening all guys with an IPSS over 7, a Qmax less than 15? What about the great research coming out of Italy by defender Emanuele Rubalotta, looking at a PVR ratio of over 20% as perhaps a way to predict those guys who are at risk for bladder outlet obstruction and detrusor underactivity? In addition, can we improve the IPSS? It's really hard for a lot of our men to get through it, especially as the educational levels are rapidly dropping, especially here in New Mexico. And let's do some research about, can we screen for bladder health starting at, for example, an age of 60? I think that is a reasonable place to start, especially looking at the 50,000 pressure flow study of Kaplan, Kausick, and Kohler of 2020. So these are some thoughts. So finally, returning to where we started, yes, we are believing in the power of P, the triple P, the prioritizing the preservation of bladder health, trying to put an end to the polypharmacy epidemic, trying to prevent late-stage BPH. Quick comment on the polypharmacy epidemic. Let me know if you think I'm being too harsh on medications. When I call it the polypharmacy epidemic, it's because we have just gotten into a bad habit, a reflexive habit. Hey, Mr. Smith, you got a problem? Take a drug. You still got a problem? Take another drug. Still got a problem? Take a higher dose. We can do better than that. And that's what it speaks to. It's not that we are against medications. We are just pro-data, pro-diagnostic, pro-bladder. So once again, we return to gratitude. Thank you all the guideline panels for both the amendment and the AUA guidelines. Thank you, AUA. Thank you, Journal of Urology. Let's keep sculpting together. Let's keep evolving forward, because I think we can do this together. And given how recent this amendment is, I agree with the LinkedIn poll. 52% of you felt that the EAU guidelines would be the most likely to first take that leap and institute the preservation of bladder health as our collective prime directive. So I think that's where our focus will be. I'm going to keep trying to work on another draft of a manifesto reflecting the EAU incontinence manifesto that came out recently, called Prioritizing Bladder Health Preservation, a manifesto for EAU, guideline reform of benign prostatic obstruction. I will try and get it out there for you guys to dismantle, re-engineer, and reimagine at the next solstice. I'm going to try and come up with 10 things that we're hoping to do together to reshape the guidelines. This just came out this morning. These are some thoughts. Please shoot holes through this, beat it up, rip it up, re-engineer it. Let me know what's wrong. What am I missing? Feel free to call me crazy. That's all good. I'm not going to be offended. Hey, life's too short. And let's see if we change our perspective from managing LUTS to changing to preserving bladder health. How can it impact our lives? And it can be, remember, simple changes can have impact. So this is kind of what I've talked about in the past. North is actually to the left when facing the rising sun. So maps actually should be oriented with us standing in the west, looking east with north on the left. Would it change the way that we see each other in this world if we were standing side by side, North America next to South America, Africa next to Europe, Russia next to Australia, as partners, as we tackle a world that is crazy? At times it feels like it's on fire, but together we can bring the light. I'm seeing it together, we as a tribe, I'm seeing the transition from what I can do better that you can too, to what we can do better that we can do together. So let us bring the light. Let us illuminate the shadows. Let us be defenders of the detrusor. Let's go save more bladders. So with that, I want to thank you all. Timothy Pansiera, thank you so much for commenting. I can't believe it's awesome that folks are actually watching this. I hope that can have an impact in your life or the people that you love. I presume you know a lot of people with prostates and bladders. So thank you for being here today, guys. And with that, I'll sign off and thank you all. We'll try and do this again next week. So be well, and we'll talk to you then. Take care.